This is EHJ Today. I'm Udo Sektum from Stuttgart in Germany, and I have with me Brent Mullerstein from Utah and Pamela Douglas from Duke University. And we are going to discuss the FACTOR-64 study. Brent, could you briefly summarize the main results of that study for us, please?
The main results are that in patients who are deemed at high risk for cardiovascular disease, who are diabetic patients, who were randomized to receive screening when they were previously asymptomatic, did not do statistically significantly better than those that just received standard optimal diabetic medical therapy.
Now that reminds one of the DIAD study that was done with sestamebe screening. This study turned out also to be negative or neutral for the use of screening. Where do you see screening for diabetic patients today?
I think the same thing happened to us that happened to the DIAD study, which was we anticipated more adverse events than we found. And I think that's because aggressive medical management for all diabetic patients is coming along during the time period of both of these studies. And it probably turns out that the most important thing you can do for a diabetic patient is take care of their risk factors.
Yes, I read a remark by Ray Gibbons, who said that he saw several patients with asymptomatic diabetes running around with their sestamebe studies and maybe with their CTs, discussing the CT, and yet their cholesterol was still way up because no one had taken care of that. Is that your personal experience as well? Or has that changed since 2010?
Well, I think that was the case back in 2004 when we began looking at the study. And we actually, to power our study, looked at the results of diabetic patients within Intermountain Healthcare from the years before that time and anticipated an adverse event rate of about 8% per year. And in the end, we had about 2% per year that actually did it.
Hard events, or including the hospital admission for unstable angina, 2%?
Yeah, 2% for all three of the primary endpoint, okay, which was death, myocardial infarction, yeah, and unstable angina.
Okay, so about 50% of those endpoints was probably unstable angina.
It was actually about even for all three.
Yeah. Oh, I see. That's interesting. Anyway, what about your recommendation? How should the general internist or the general practitioner deal with a diabetic patient today when he is concerned about this patient being at high risk yet asymptomatic? Yeah,
what he should do is aggressively control the risk factors that he can control. My recommendation is that they target LDL cholesterol down to 70, just as if it was secondary prevention. Our study did show that 70% of the patients had some degree of atherosclerosis, even though they didn't have any other signs or symptoms. And so I think justifies aggressive management as if it was secondary prevention.
Pamela, do you have any?
I would just underscore that point that the imaging, whether it's nuclear scanning or CT scanning, identifies disease to be very prevalent in these patients. And so they are indeed a high-risk group because of what's happening in their coronary arteries and presumably other circulation. But so the testing itself is doing its job. Mm-hmm. What we need to do is understand what the correct treatment is, you know, how that testing information should change our care to affect outcomes. And as Brent said, it really tells us to go back to basics and focus on getting blood pressure down, getting the lipids down, controlling the diabetes. And those basics are so important, but in fact, in the United States at least, probably under 10% of diabetic patients are actually at goal for every cardiovascular risk factor, which means 90% of the diabetic population, there is a therapeutic change that could be introduced that would improve their outcomes. But you don't need to image them to find out.
Absolutely. But when you talk to GPs, and I often do, they are more concerned that they need to do extra things than concerned about to do what they can do. And how do you see this study that you just finished, the FACTOR-64 study, in the context of teaching those who treat the diabetic patients?
That can kind of be explained as to why our study ended up being underpowered. And that is because right at the same time we started the study, Intermountain Healthcare, which is a large organized healthcare consortium, set about, in combination with the cardiovascular program and also the primary care clinical program, a concentrated effort to manage all of the diabetic patients. And they set targets and they began to monitor them so that the primary care physicians received reports saying your patient's diabetic patient's LDL is too high, your patient's diabetic blood pressure is too high, and please do something about it. And they tracked them. And so in essence, that sort of wrecked our study, but helped all of the patients within the Intermountain Healthcare system, because the baseline LDL levels and baseline blood pressures, and during the follow-up of the study, were much better than has been reported in the average world.
But is it not a bit disconcerting that we need external forces to tell us what we need to do as a profession, and then it works?
That is true. I think that partly happens as a clinician myself. Patients don't come in saying, I'm really worried because my LDL cholesterol is still 120. They come in saying, I've got a cough. Can you please take care of my cough? Or I've got my knee hurts, or something that symptoms that drives them and that it distracts us as physicians. And so I think it's justifiable to set up sort of institutionalized systems to make sure that we don't forget the things that perhaps are the more weighty matters, but not necessarily the thing the patient cares about when they come to see us.
You're right. Now, when we talk about surveillance, do you think it would be a good idea if the insurance companies just forbade us to order that type of test we just discussed, CT for asymptomatic diabetics, or nuclear scans for these people? Is that what we need?
I don't like insurance companies forbidding me from ordering things. I would still like to have the option. I think it's probably more appropriate to educate physicians so that they know when things might best be done and might not be done, and perhaps taking away, this is sort of a political comment, taking away the disaligned incentives, so that if I order something and I get paid more because I ordered it, that can be changed.
Yeah. But still, we need some kind of surveillance, maybe some professional surveillance then, instead of...
I would much prefer the American Heart Association to police me rather than the insurance company. One thing I can say is that some of these patients, I think, actually were benefited, because there were some, not enough to make a statistically significant difference in the population, who had severe disease and even reduced left ventricular function, and by any guideline would benefit from revascularization, and they went on and got revascularization, and I think they did better because of it. But the common finding I found is when they came out of their revascularization, they said, wow, I feel so much better. Mm-hmm. And so what had happened is they were labeling themselves as asymptomatic and blaming their reduction in functional capacity on age. So I do think that it's still beholden upon us in these high-risk populations to listen to our patients carefully and determine if they're really asymptomatic or not. And if they're not, if they are symptomatic, then proceeding with some of these tests I think is justified, but just not in everyone.
Very good point. Final comment, Pamela?
I would just respond that the appropriate use criteria that American College of Cardiology has done speaks very clearly regarding testing in asymptomatic individuals as being rarely appropriate. Of course, patients have individual quirks that can sometimes change that to be appropriate in an individual case. But in general, asymptomatic testing in asymptomatic individuals is not seen as beneficial. And I think this is a beautiful study demonstrating that now with hard randomized controlled trial evidence, to say that appropriate use criteria ranking of rarely appropriate is the right one.
Absolutely. I think that is a very important statement, and that I think is something for our listeners to take home. And we're going to look forward to the publication, which is going to come up tomorrow.
That's correct.
And where is it going to?
It is going to JAMA.
To JAMA. That's very good. So I recommend you all to read JAMA. I would like to thank Pamela Douglas and Dr. Mullerstein for the interview. Thank you.